Okay, so starting with anatomy of uvea, accommodation, and with its anomalies. So uvea has three parts: iris, ciliary body, and choroid. Ciliary body has pars plicata and pars plana. Pars plana is the most avascular structure, and plicata has pleats or ridges. Iris and pars plicata, that is anterior uvea, and inflammation is anterior uveitis. Plana is intermediate uveitis. Choroid is posterior uveitis. Iris anatomy. It has increased vascular. Pigmentation is due to melanocytes. Thickness is variable. Thickest part is collaret between boundary between pupillary zone of iris and ciliary zone of iris. Pupillary and ciliary zone of iris, that collaret boundary is the thickest part. Thinnest part is root of iridodialysis. So thinnest part is the root of iris, which is a site for iridodialysis, detachment of iris. Muscles of iris. There is two muscles, sphincter pupillae and dilator pupillae. Sphincter pupillae causes meiosis and dilator pupillae causes mydriasis. So autonomic nerve supply and final nerve supply. Sphincter pupillae has parasympathetic control, inhibitory, via oculomotor nerve. Oculomotor nerve's infraorbital branch, which is to inferior oblique muscle, and short ciliary nerve, postganglion. Dilator pupillae mydriasis has sympathetic control, excitatory control. It's coming for hypothalamus, primary spinal cord, short ciliospinal bulge, crossing lung parenchyma, secondary neuron. This neuron can be damaged while resection of Pancoast tumor and can lead to damage or to superior cervical ganglion and loss of sympathetic supply to eye. Along internal carotid artery, the third degree neurons will travel and become long ciliary nerve. So final nerve for sphincter is short ciliary, and final nerve for dilator pupillae is long ciliary. How will you remember? S for short, S for sphincter. Note, parasympathetic cranial nerves are 3, 7, 9 and 10. Which are the parasympathetic nerve? 3, oculomotor, 7, facial, 9, hypoglossal, 10, vagus. Oculomotor nerve has superior branch and inferior branch. Superior branch supplies superior rectus, inferior rectus. Easy to remember. Then superior branch supplies levator, like upper levator superior palpebris superioris, and inferior branch supplies inferior oblique. So superior branch of oculomotor supplies superior rectus, and inferior branch of oculomotor supplies inferior rectus. Horner's syndrome, oculosympathetic palsy, paralysis of sympathetic supply. What is Horner's syndrome? It is paralysis of sympathetic supply. Causes. So here there are many causes given here. In this diagram they have shown the hypothalamus. Below that, this nerve is ophthalmic division of trigeminal nerve, and it is elongating as long ciliary nerve. And then there is another branch going to sweat glands of forehead, and below that to smooth muscles of eyelid. Internal carotid artery to sweat glands of face. External carotid artery. Third order neuron, postganglionic, superior cervical ganglion. C2 to T1, second order neuron, preganglionic. So the first order neuron, central, that is from hypothalamus to ciliospinal bulge. I can't read it, but T1, C2 to T1, let's suppose. So C2 to T1, first order neuron from hypothalamus to this bulge. Causes of lesion here is brainstem lesions, syringomyelia, diabetic autonomic neuropathy, Wallenberg syndrome. Then coming to second order neuron, preganglionic, here, ciliospinal bulge to superior cervical ganglion in the neck. So from cerebrospinal bulge to superior cervical ganglion in neck, and causes for damage to this neuron is Pankos tumor, carotid and aortic aneurysm, neck lesions. Then third order neuron, postganglionic, the postganglionic neuron. Causes to this neuron is cluster headache. This ascends to cavernous sinus and supply dilator pupillae via long ciliary nerve. Causes cluster headache, internal carotid artery dissection, otitis media, cavernous sinus mass that can damage it. Clinical features: high maple, that is the mnemonic. High H is for heterochromia iridis, ipsilateral hypochromia only in congenital Horners. In congenital Horners, you can see ipsilateral hypochromia or heterochromia iridis. Inferior eyelid elevation, paralysis of inferior tarsal muscle, analogous to Muller's muscles in upper eyelid. So there could be inferior eyelid elevation in Horner syndrome due to paralysis of tarsal muscle in the inferior eyelid. Tarsal muscle is the analog of Muller's muscles in the upper eyelid. Heterochromia could be right eye hypochromic, left eye hyperchromic. Horner's confirmed clinically. Meiosis, paralysis of dilator pupillae, constriction occurs. Because there is dilatation of dilator pupillae, there is meiosis. Anhidrosis, absence of ipsilateral sweating, there is no sweating. Ptosis, drooping of upper eyelid due to paralysis of Muller's muscle. Drooping of upper eyelid due to paralysis of Muller's muscle. So Muller's muscle is also paralyzed and tarsal muscle is also paralyzed. Loss of seniospinal reflex. Loss of ciliospinal reflex. Relative anophthalmosis. Ptosis plus inferior eyelid elevation, sunken appearance of the eyeball is not a true exophthalmos. So relatively the eye appears sunken. Note: Muller's muscle or superior tarsal muscle, LPS, levator palpebral superioris, supplied by cranial nerve 3, it all causes elevation of eyelid. So Muller muscle, tarsal muscle, levator palpebris superioris, cranial nerve 3, it all causes elevation of eyelid. Diagnosis: detection of Horner syndrome. So diagnosis: detection of Horner syndrome if cocaine test blocks reuptake of norepinephrine. Increased norepinephrine in cleft will cause dilatation of pupil, normal pupil. No norepinephrine in cleft, no dilatation, no norepinephrine released, Horner's syndrome. So you can do cocaine's test. Cocaine's test, because cocaine will inhibit the reuptake of norepinephrine in the eye. So in a normal eye, norepinephrine will be collected and it will cause dilatation of the pupil. But in Horner syndrome, there will be no norepinephrine collection, so there will be no dilatation of the pupil. Which muscle is paralyzed? Dilator pupillae. 1% epiraclonidine test, alpha agonist. 1% epiraclonidine test. Normal sensitivity, alpha 2 meiosis more than alpha 1. Horner's de-innervation hypersensitivity of alpha 1 receptor, mushrooming. Selective alpha 1 more than alpha 2, dilatation of pupil. So 1% epiraclonidine test. Epiraclonidine is a alpha agonist. Normal sensitivity, it is more affinity to alpha 2 receptors compared to alpha 1 normally, and through alpha 2 it causes meiosis. But in Horner's syndrome, there is something called denervation hypersensitivity of alpha 1 receptors, mushrooming. So no now supply, so increased sensitivity, increased receptors. So selective alpha 1 receptors more than alpha 2 will cause dilatation of pupil. So epiraclonidine test also, you will see dilatation of pupil. Localization of the lesion. Now you have to see where the lesion is. So that is done by 1% amphetamine test. 1% amphetamine test. X by displacement. Hydroxyamphetamine is used. HAH, hydroxyamphetamine, promotes release of norepinephrine into postsynaptic cleft. If there is dilatation of pupil, central pathway affected, central Horner syndrome, or preganglionic pathway affected, preganglionic Horner syndrome. No dilatation of pupil, postganglionic pathway final affected, postganglionic Horner syndrome. So when you give hydroxyamphetamine, it will increase norepinephrine in the postsynaptic cleft, that is in the neuron, in the postsynapse. The norepinephrine is increased. If it is a final neuron that is affected, there is no following neuron for this norepinephrine to act on. So that's why, and the muscle paralyzes dilator pupillae. So dilator pupillae will not act, and there will be no dilatation. So that confirms postganglionic Horner syndrome, because there's no ganglion to act after that. No neuron. So no dilatation means postganglionic Horner syndrome. Something's happening after the ganglion. While if there is a dilatation, it could be central pathway or preganglionic. Now note causes of mydriasis and causes of meiosis. Mydriasis is your dilatation of pupil. So first is internal ophthalmoplegia, tonic pupil, Holmes-Aldi pupil, sympathomimetics, closure angle glaucoma, oculomotor third nerve palsy, pupil cannot constrict, Mydriatics like atropine, hometropine, tropicamide, belladonna poisoning. So all these things will cause your pupils to dilate. Then causes of meiosis. Horner's syndrome, we just learned about it. Pontine hemorrhage. If there is pontine hemorrhage, you have your meiosis. Iridocyclitis. If there is inflammation of iris and ciliary body, there that is the anterior uveitis, you have small pupil. Clonidine, carbolic acid. OP poisoning like morphine. Parasympathomimic drugs like phenothiazine, pilocarpine. Sleep, sedatives and barbiturates. Sedatives and barbiturates. So Mydriatics is atropine, hometropine, and tropicamide. What does atropine, hometropine, and tropicamide do to the eye? Mydriasis. Coming to ciliary body functions. Secretions of aqueous through ciliary processes. Pars plana, site of entry into vitreous cavity, relative avascularity, decreased chance of bleeding. So pars plana, being the most avascular structure, is the choice of entry into the vitreous cavity, not the aqueous chamber, vitreous cavity. Accommodation, contraction of ciliary muscle, increased power of lens, helps in near vision, relaxation of zonules. Components of near reflex. Accommodation, convergence, inward movement of both eyes, and meiosis. Accommodation, what is near reflex? Components 3. Accommodation, convergence, and meiosis. Here in the first thing, you see the ciliary muscles are relaxed, ciliary zones are tensed, the anterior surface is flat, so the rays are converging on the retina, parallel ways. So this is a near object, ciliary muscles are contracted, zonules are slack, so lens became thick, anterior curvature, diverging rays from a near object are contracted. So increased curvature of anterior surface, increase AP diameter, increased power of lens helps with near vision. Anomalies of accommodation. Presbyopia, physiological insufficiency of accommodation. Presbyopia is physiological. Difficulty in near vision, using phones, reading newspaper, that is difficulty in near vision. Like using phones, reading newspaper, onset around 40 years of age. It comes up around 40 years of age. Treatment, spectacles. Convex or converging. You need converging spectacles. Progressives are more preferred than bifocals, more than executive lenses. Power depend on age. At 40 years, plus 1 diopter is required. Eventually, additional 5 years, 0.5 diopter added to power. Types of spectacles. For patients only needing near vision lenses, monofocal lenses. Power restricted to central arc glass configuration. No power in the peripheries. restricted field of view. For patients already using glasses for far visions, progressive lenses, appealing due to seamless transition of lens, covers near, intermediate, and far vision. Bifocals or bifocals, disadvantage, cosmetically unappealing and no provision for intermediate vision. Bifocals, you can see at the bottom you have near vision and at the top you have far vision. Executive bifocals, so top far vision, below near vision, pupil bisected by line between the lens. Obsolete in most cases except in pediatric aphakia. It is only used in pediatric aphakia. Spasms of accommodation. Continuous state of contraction of ciliary muscles. The ciliary muscles are constantly contracted. That is called spasm of accommodation because you are now fixed to near vision. So loss of far vision, pseudomyopia. It is not true myopia, it is pseudomyopia. Treatment, cycloplegia, relaxation of ciliary muscles. Drugs, mydriatics and psychoplegics. Atropine, hometropine, cyclopentolate. So, or only hometropine or only cyclopentolate. So cycloplegia is you are paralyzing the ciliary muscles. How do you paralyze it? Atropine, hometropine,